Hello, welcome to my YouTube channel. I'm Dr. Mirela Apochi, resident cardiologist. In the previous video, we discussed a clinical case of atrial fibrillation. For this video, we will have a general overview of atrial fibrillation and we will find out why atrial fibrillation is never alone but accompanied. First of all, I would like you to understand that atrial fibrillation is a major problem worldwide and its detection as early as possible is beneficial. Atrial fibrillation is the most common sustained cardiac arrhythmia. The recent worldwide epidemiological data on atrial fibrillation confirms the emergence of this condition as a global epidemic with significant and progressive effects on estimated disability and mortality. The median change in prevalence was higher in developed countries, with the largest increase noted in North America. How can we detect atrial fibrillation? To answer the question, we must first understand a little what atrial fibrillation means and by what mechanism atrial fibrillation occurs. Atrial fibrillation is a heart rhythm disorder that occurs in the top chamber of your heart, the atria. When in atrial fibrillation, there is a fast and chaotic electrical activity in the atria. In other words, instead of the atria having organized rhythm and motion, normal sinus rhythm, the atria goes so fast there is no meaningful contraction. Many impulses will reach the atrioventricular node and that will govern how fast the lower chambers, the ventricles, will contract and how fast your heartbeat will be. Therefore, atrial fibrillation risk factors induce structural and histopathological changes to the atrium that are characterized by fibrosis, inflammation, cellular and molecular changes. Persistent atrial fibrillation further induces electric and structural remodeling that promotes perpetuation of atrial fibrillation. Atrial fibrillation also may lead to the development of additional risk factors that further alters the atrial substrate. Finally, atrial fibrillation is associated with several clinical outcomes. The diagnosis of atrial fibrillation requires heart rhythm documentation with a standard 12-lead ECG recording or a single lead ECG tracing of at least 30 seconds, showing irregular air-air intervals with absence of distinct repeating P waves. There are two terms of atrial fibrillation currently used: clinical atrial fibrillation and subclinical atrial fibrillation. Clinical atrial fibrillation defines symptomatic or asymptomatic AF that is documented by surface ECG, the same electrocardiographic characteristics as I mentioned before on the previous slide. Individuals without symptoms associated to atrial fibrillation in whom clinical AF is not previously detected, there is no surface ECG tracing of AF, it refers to us as subclinical AF. This is not the topic of today's discussion. We will make another video that will focus on subclinical AF. How can we answer the previous question? The detection of atrial fibrillation? Well, from a clinical point of view, it's difficult to detect it. As you can see written on the slide, a large proportion of people, 50 to 87%, are initially asymptomatic with possible less favorable prognosis. And what is more interesting is that the recurrences of atrial fibrillation are commonly asymptomatic. So it requires a serious routine control. Fortunately, I could say fortunately, those who have symptoms such as palpitations, dyspnea, fatigue, can contact a cardiologist for the necessary investigations. Don't forget, sometimes it's possible that symptoms can be related to undertreated conditions for example, hypertension or heart failure. What are the risk factors that increase the incidence of atrial fibrillation? They can be non-modifiable, such as age, genetics, male sex, ethnicity, and modifiable like hypertension, diabetes, obesity, obstructive sleep apnea. These modifiable risk factors are potent contributors to AF development and progression. Why are we interested in knowing these risk factors? Good question. Well, if a person doesn't have any of the symptoms mentioned above, but the person is old, like 75 years old, hypertensive, has diabetes or another associated heart disease, then the person is in the category of patients with high risk of developing AF. Knowing this, she or he will consult a cardiologist to perform an ECG to detect early episodes of AF and prevent complications associated with AF. AF-related outcomes are numerous and severe. Does that surprise you? Well, through various mechanisms, AF leads to fatal complications. Statistics show that AF is independently associated with an overall 3.5-fold mortality risk increase. The most common causes of death among AF patients were heart failure, malignancy, infection, or sepsis. Cardioembolic strokes associated with AF are usually severe, highly recurrent, with permanent disability. AF may lead to cognitive impairment ranging from mild dysfunction to dementia via clinically apparent or silent stroke. 60% of atrial fibrillation patients have significantly impaired quality of life or exercise tolerance. Approximately 30% of atrial fibrillation patients have at least one hospital admissions annually. The most common reasons for hospitalization of atrial fibrillation patients were cardiovascular disorders, non-cardiovascular disease causes, bleeding. I choose to talk about AF screening because multiple factors, such as previously unknown AF detection in about 10% of all ischemic strokes, high prevalence of asymptomatic AF, have intensified international initiatives to implement screening for AF in clinical practice. Mobile health technologies such as smartphones, apps, and watches are rapidly developing for AF detection. Caution is needed in their clinical use, as many are not clinically validated. When AF is detected by a screening tool, including mobile or wearable devices, a single lead ECG tracing of 30 seconds or 12 lead ECG showing AF analyzed by a physician is necessary to establish a definitive diagnosis of AF. Often occurring in patients with cardiovascular risk factors, AF may be a marker of undiagnosed conditions. So all patients will benefit from a comprehensive cardiovascular assessment. The diagnostic evaluation of AF patients should include complete medical history and assessment of accompanying conditions, stroke risk, AF-related symptoms. A 12-lead ECG is recommended in all AF patients to establish the diagnosis of AF, assess ventricular rate during AF, and check for the presence of conduction defects, ischemia, etc. Laboratory tests, thyroid and kidney function, serum electrolytes, full blood count, and transthoracic echocardiography to assess left ventricular size and function, left atrial size, valvular disease are needed to guide treatment. In selected AF patients, long-term ECG monitoring is recommended to assess the adequacy of rate control or to relate symptoms with AF episodes. Most AF patients need regular follow-up primary care to ensure continued optimal management. Thanks for watching. I hope you learned something. Please don't forget to like and subscribe to my channel.